Yeah, perfect.
Okay. Okay.
Yeah.
So
So
I
we
think we
start
should be
in,
starting.
yeah.
Yeah, perfect.
So we'll start.
Yes, yes.
Yeah. So good evening, everybody, and welcome to another edition of and Thursday evenings with ICCM Kolkata. It gives me great pleasure to have
I know.
Dr. Tapas Kumar Sahu as
I
our
want good.
speaker
I
for
want
today.
sleep. I want.
Requesting everybody to kindly keep your microphones muted, please. Yeah. So Dr. Tapas Kumar Sahu is a very well-known personality as far as academics is concerned, not only in core critical care, but he is the secretary of the Nephrocritical Care Society. He is the associate director and head of critical care at Vedanta Hospital, Ranchi. He's also the international Asia Pacific representative of the European Society of Intensive Care Medicine between 2018 to 2021. And most important of all, he's a very passionate academician. So, without further ado, I hand over the session to Dr. Tapas Sahu, and we welcome all of you for today's session.
So
Tapas, over to you.
yeah. So good evening, everyone. I think good afternoon also, because some of my friends are from Middle East, some of my friends are from UK also. So they have joined. So hello, everyone. And it gives me immense pleasure to get some invitation from one of much acclaimed academician, Dr. Saswati Sinha, and ISSM Kolkata, which is very close to me in terms of the academic endeavors they do. And I know it is a topic which is not core nephrocritical care, which I do for last 1 year or 2 years or so in terms of the society perspective. But yes, it is something related to heart, and we know the importance of heart in our life. So let's start with the introduction in some different way. We know there are like two best friends, and the first friend is septic shock, which as intensivist we always put our like whole focus in treating. But there is another friend who is also at the same time so much of important to our own understanding as well as our practice, that is cardiogenics. And today we are going to discuss about the second friend, that is cardiogenic shock. So my disclaimers from the very beginning: I am associated with a very novel initiative, that is 360 critical care, which trains many of the students across the world for the different critical care exit exams. And I am also associated with Nephrocritical Care Society, which is not directly associated with today's discussion. Now, without any further delay, let's start with a clinical case to set the pace for our today's discussion. Practical case, we always in our day-to-day practice witness this type of case, and today I think many of us must have seen this type of case in their emergency department or cardiac ICU or in medical ICU as well. A 68-year-old woman arrives at the emergency department with complaints of dyspnea and lightheadedness. Her family states that she has a weak heart and report history of hypertension that is being treated with multiple agents. In the emergency department, when you have seen the patient, she is somnolent with cool and mottled extremities. Heart rate is 45 beats per minute with blood pressure is pretty much okay. 114 by 71 millimeter mercury and SpO2 of 88%, which is a little bit concerning for me at this point of time. Now, the ECG showing junctional bradycardia with no ischemic changes. At the first instance, I just go through rapidly the ECG. Now, when I am auscultating at the standard clinical examination in the emergency department, I am getting crackles diffusely through her lung fields with decreased air entry bilateral. Now, straightforward question for my trainee friends: what could be the problem she is having, and how would you approach? I'm not expecting any answer at this point of time, but I would definitely expect a lot of interactions because I have questions for you in between to just make you focused in my presentation to understand this is like something which is very important, pivotal in our clinical practice. Now, my talk would be simple and it would be critical care oriented. I am not replacing any cardiologist in your cardiology department. There would be many infographics and algorithms to make you understand the approach. And as a teacher, I always focus on a structured approach rather than beating around the bush and not telling about the way how we deal at the bedside. It would be a structured approach, and everything that I would be talking today for next 30 to 40 minutes are evidence based. Now, why it deserves to be a separate class? Why Dr. Saswati and ISS in Kolkata thought about having a cardiogenic shock class separately? If it is related to matters of the heart, I don't think so, as we are like all related to academics, not related to the typical Bollywood movie. But definitely, the concern for me at this point of time that survival of the cardiogenic shock patients that has not changed substantially despite maybe I would say 30 to 40 years of the research as well as the literature search as well as the practice as well as the updates that we have come across in our cardiology cardiac critical care. Now, do you know what is the mortality of the patients at 30 days following diagnosis of cardiogenic shock? It is shocking. It is 30 to 50%. So it is not less than what we are dealing in septic shock. So both the two friends are having the same fate at this point of time. Both the septic shock as well as the cardiogenic shock, if I would say at 30 days following the diagnosis. Now coming to the history. The cardiogenic shock history dates back to the 1967, and this is the first landmark study literature that has been published in any gem. And do you know, can you see the author here? Thomas Killip. So any smart mind right now, they can just correlate. We have the Killip's classification as well, and we all use it in our clinical practice, in our classes related to cardiology. So let's see that this is about 250 patients Killip has studied in his coronary care unit in 1967, and he has divided the Killip classification into 4 parts: class 1, class 2, class 3, class 4. Class 1, no evidence of congestive heart failure. Class 2, when we are suspecting and we are getting S3 gallop and bivascular rails. Class 3, when we say that my patient is having pulmonary edema. How? It is a clinical examination because at that time there was not having POCUS or any hemodynamic advanced monitoring. So rails greater than halfway up the lung fields. Now coming to the Killip, class 4 is cardiogenic shock. So 1967, he mentioned that if my patient is in the class 4 category, then they are labeled as cardiogenic shock. And do you know 19% of the 250 patients, so it would be around, I would say 50 patients were in the class 4 at the time of presentation to the hospital. And their mortality was staggering 81%. That means if my patient is right now having cardiogenic shock, I could not diagnose this at the right time. I could not start the treatment at the right time. And it was like something mismanaged in some or other way. So the mortality is almost right now 80%. That means 8 out of 10 patients are dying. Now, the second literature, which is of like, I would say it's interesting, is published again in NEJM, and that was in 1976. Again, that is related to another like stalwarts in the cardiology. You can see again the first name, Forrester. So again, any smart mind right now, they can correlate who is Forrester. So Forrester's classifications, again, 1, 2, 3, 4, based on the pulmonary capillary wedge pressure and cardiac output. Based on that, this is corresponding with the Killip classes. So subset 4 is the most concern for me. That is elevated pulmonary capillary wedge pressure, and simultaneously I am also having decreased cardiac output. But the subset 1 would be both normal. Subset 2 would be elevated pulmonary capillary wedge pressure, but my patient is still having normal cardiac output. Subset 3, normal pulmonary capillary wedge pressure, but decreased cardiac output. So this is something which is right now the literature search that I thought about, like, starting from the beginning. Now, if I would be making cardiogenic shock in one slide, and I am expected to answer in like what is cardiogenic shock? So it's a state of inadequate organ perfusion due to primarily cardiac pump dysfunction. It is multifactorial and it is a hemodynamically complex syndrome due to impaired myocardial contractility. And this would be resulting in profound and refractory circulatory collapse if I am unable to manage it at the right time, leading to systemic hypoperfusion, metabolic acidosis, and finally refractory multi-organ system dysfunction. So this is something in nutshell about cardiogenic shock. Now, if I would be analyzing the epidemiology, cardiogenic shock remains the most common type of shock in cardiac intensive care unit worldwide. Surprisingly, previously the primary disorder was LV dysfunction resulting from like acute myocardial infarction. So myocardial infarction was the leading cause leading to the cardiogenic shock. But in recent years, this is again published recently, 2024 Frontiers in Cardiovascular Medicine. Now, the acute decompensation of the congestive heart failure is actually replacing AMI, acute myocardial infarction, as the most common underlying etiology. More than 50% of the admissions for cardiogenic shock are due to ADCHF, not the AMI. Maybe this is related to we are more concerned and like we are more updated about the AMI, myocardial infarction diagnosis management, and we are right now starting with the early revascularization strategies immediately based on the clinical diagnosis. So that is resulting in the more AMI survival, but somehow the chronic heart failure patients are on and off coming to the ICU, and that is the cause for the cardiogenic shock in our coronary care unit. Now, first question to some of the brilliant minds here, where you are thinking cap. Cardiogenic shock is most often associated with which LV wall involvement in MI? I know you all know the answers, so I'll not wait for your answers, but you can post in the chat box. Inferior wall, lateral wall, anterior wall, and posterior wall. Which one? You can try, and Dr. Saswati would be looking at the answers. Now, the next question, where you are thinking cap here. Again, percentage of patients with cardiogenic shock, they have shock at the time of initial presentation. 25%, 50%, 75%, and 90%. What would be the percentage of patients they are having cardiogenic shock with shock at the time of initial presentation to your emergency department or to any of the primary healthcare? That is again a very interesting thing. So I am not going into the detail of the answers. I would be answering these questions at the end of my presentation if there are any confusions. Now, coming to the definition of cardiogenic shock, clinical definition varies from country to country, from society to society, from like the units to unit as well. But usually it includes hypotension, systolic blood pressure less than equal to 90 millimeter mercury, despite adequate filling pressure and signs of organs hypoperfusion. So this would be there definitely, but it is usually includes hypotension. It is not the mandatory definitive diagnostic criteria to label that my patient is having cardiogenic shock. So read between the two lines. Now, it is a clinical triad. Cardiogenic shock is a clinical triad. It would be comprising of ineffective cardiac output. There would be tissue and organ hyperperfusion and normal or elevated cardiac filling pressures in the form of pulmonary congestion. So this is the clinical triad of cardiogenic shock, which you have to remember. Now, a thought-provoking questions. Can cardiogenic shock present with hypoperfusion even in the absence of hypotension? I expect yes or no. I know you all know, so I'm not waiting for the answers again, but these are some of the like thought-provoking questions that sometimes like confuse us at the bedside in our teaching classes. Now, there are certain clinical pearls to give me solid evidence what I am actually trying to explain today. Shock is a state of hypoperfusion. So definitely there would be some clinical features, some of the biochemical signs of hypoperfusion. Hypotension.
तुम्हारा ये
Hypotension
कहाँ पे है?
is, I request all of you to please mute your audio. Hypotension is not required for the definition of shock state. And surprisingly, patients in the early shock can have normal or high blood pressure through a compensatory mechanism, while your tissue perfusion may be significantly impaired. So maybe you would be getting the compensatory mechanism that is making your blood pressure to be normal or more than normal. So you should not be confused with the blood pressure. So blood pressure is not the diagnostic criteria for hypotension like your hypoperfusion. Now, early recognition of hypoperfusion signs identifies the high risk patients regardless of hypotension, and that is the essence of today's class. We need to identify the high risk patients when the patient is still not having the frank hypoperfusion. Cardiogenic shock is a clinical diagnosis, and hemodynamic parameters like reduced cardiac index, elevated pulmonary capillary wedge pressure are not mandatory in the clinical practice. So you should not always depend that why my patient is having cardiac index to be normal, or no, there is no elevated PCWP, then why or how I will label my patient to be in cardiogenic shock. Now, again, one more true or false question. Shock tends to develop earlier in patients with single vessel coronary disease than in those with triple vessel disease. True or false? That means any patient with a main stem, you will say the LAD block, they would be having shock at the time of presentation earlier, or any patient with triple vessel disease, they would be having the shock earlier when at the time of presentation. True or false? Okay, so all the answers will be analyzing at the end if we will get some time. Now, next point is the definitions from the literature. So the definition of shock from the three trials, shock trial, IABP shock 2 trial, and European Society of Cardiology guideline 2021, they are highlighting it in terms of two criteria: clinical criteria, hemodynamic criteria, and in the third, as per the European Society of Cardiology, laboratory criteria. So clinical criteria, please try to remember myocardial infarction complicated by left ventricular dysfunction would be the first clinical criteria. Systolic blood pressure has to be less than 90 millimeter mercury for more than 30 minutes, or you are requiring some catecholamine support to maintain the systolic pressure more than 90 millimeter mercury, and you are getting end organ hypoperfusion in the form of urine output less than 30 ml per hour, or you are getting cold extremities. So this is the clinical criteria as per the shock trial. Coming to the hemodynamic criteria, you will get cardiac index less than 2.2 liter per minute per meter square, and you are also getting simultaneously pulmonary capillary wedge pressure more than 15 millimeter mercury. So this is the clinical criteria and hemodynamic criteria. Now coming to the IABP shock 2 trial, it is the same thing as for the shock trial, that you are getting acute myocardial infarction, systolic blood pressure less than 90 for more than 30 minutes, or you are getting requirement of the catecholamines to maintain the systolic blood pressure more than 90, and there is also clinical pulmonary congestion, impaired end organ perfusion with altered mental status, cold, clammy skin on the limbs, urine output less than 30 ml per hour, and lactate more than 2 millimole per liter. So lactate has been added here. Now, as per the European Society of Cardiology, again the same thing. I'm not repeating. Clinical criteria, clinical hypoperfusion, laboratory hypoperfusion in terms of you are having the ABG, you will get metabolic acidosis, elevated serum lactate, and elevated serum creatinine. That means the other organs have started to also fall into prey. Now, there is another classification where they have divided into A, B, C, D, E. You must be knowing critical care people are very fond of remembering in the the mnemonic A, B, C, D, everything, airway, breathing, circulation. In the cardiology part also, they have thought about forming something related to A, B, C, D, E. I'm just trying to explain it in the next slide. They have start with the pyramid of A. A is at risk. B is the beginning. C is the classic cardiogenic shock. D is the deteriorating. E is the extremis. That means it is the, you would say, the most severe form of cardiogenic shock. Now, A, when a hemodynamically stable patient who is not experiencing any sign or symptoms of cardiogenic shock, but is at risk for its development. That means it is in the first few minutes of having large, like acute MI or decompensated heart failure. So if you are picking up at this point of time, maybe you would saving almost 90% of the patients. But B are the patients who are having clinical evidence of hemodynamic instability, maybe in the form of hypotension, tachycardia, or abnormal systemic hemodynamics if you are having some of the advanced monitoring without hypoperfusion. That means you are still not getting the features of hypoperfusion. But C is the classic one. That means here you will get the clinical evidence of hypoperfusion. So hypoperfusion C. And definitely at this point of time, you would be thinking to start with pharmacology or mechanical support. And hypotension is usually present. So for A and B, compensatory mechanisms are actually trying to maintain the patient's hemodynamics. But at C, that means you are actually failing. And the patient is right now showing all the signs and symptoms of hypoperfusion. Now, D is the deteriorating. That means still right now this patient has clinical evidence of shock, but you are unable to maintain the patient or improve the hemodynamics despite escalation of the therapy. Maybe pharmacology, maybe having a mechanical circulatory support. Now, coming to the E, a patient with refractory shock, or now the patient has landed up in the circulatory collapse, maybe in the form of cardiac arrest as well. So that is the extremis. So the A, B, C, D, E is just for remembering it in a proper way, and C is the most concern. After this, you have no time. Patient will land up at any point of time to cardiac arrest or circulatory collapse. Now, dynamic evolution of cardiogenic shock also based on this A, B, C, D, E. So if you are trying to have some or other things at this point of time C, I have already explained, you can reverse back to A, or patient will be all right. But after C, if you are unable to maintain, maybe the patient is not able to cope up with all the stress and strain related to the cardiogenic shock. Sometimes a patient coming to the emergency department with cardiac arrest following cardiogenic shock or massive MI, something like that. So directly it would be ending in E. So acute catastrophic event with prolonged cardiac arrest arrives in the stage E. That means you are actually escaping all the things. But most of the time we will be going through A, B, C. Now, this is another Forrester classification I have shown in the first few slides. So this is the Forrester classification. You can see here the x-axis, y-axis, cardiac index 2.2 is the sweet spot for me. So if it is more than this, I'm happy, well perfused. If it is less than this, definitely it is a cold shock, I would say. And in the form of cold extremities, oliguria, renal failure, hyponatremia. That means failure. Now, well perfused warm extremities, adequate urine output, preserved renal function, and normonatremia. Now, if it is right now in the pulmonary capillary wedge pressure, so it is the 18. We all know PCWP 18 again is the sweet spot. And if it is less than this, I'm happy. The lungs are dry. So it is related to heart and the body, and this is related to lungs. So if it is more than 18, it is pulmonary edema. That means wet. So if both the two things are here, like the cold as well as wet, so the mortality is almost more than 50%. That means cardiac index is less than 2.2 and pulmonary capillary wedge pressure is more than 18. So it is the Forrester classification class 4. But if it is in the class 1, where it is warm as well as dry, so lungs are also happy and the heart is also happy. So it is a happy phase. So my target would be keeping my patient to be in the class 1, or maybe before that I should be able to treat my patient. Now, There is again another phenotypic classification which is coming up in a bigger way in cardiogenic shock. What is that? It is the metabolic classification. That means whether it is non-congested cardiogenic shock, that means the RV and LV are pretty much okay. Whether it is cardiorenal syndrome, that means the heart problem has right now resulted in the hypoperfusion of the kidneys, resulting in the cardiorenal syndrome, or it is cardiometabolic syndrome. That means already other organs have also started to act in a little bit difficult way. That means liver as well as the other, like maybe gut, maybe the CNS. Now, what is the fate of these phenotypes? Why these phenotypes have been started in the discussion? Because if my patient is having non-congested cardiogenic shock, that means hemodynamics are normal, but with poor tissue perfusion and organ function. So mortality is least 10 to 28%. But if my patient has landed up in the cardiorenal syndrome, that means hemodynamically fragile with fluid overload and poor renal function. So it is almost touching 30 to 45%. But when my patient has landed up in the multi-system organ failure and hemodynamic is unstable, it is almost more than 50% mortality. So that's why we need to treat my patient in terms of the phenotypic way rather than only a blanket therapy of cardiogenic shock. Now, there are other phenotypes are also coming up, and this is a very good article just this month only published in the chest. I would request all of you to go through this article. This is the left ventricular involvement, right ventricular involvement, or biventricular involvement. This is again another type of classification. And there is another classification with MI, without MI, because the management plan completely changes. If my patient is having acute MI, definitely my management would be going into PCI, CABG, revascularization therapy. If my patient is having some other cause, definitely the management would be treating the cause rather than giving all the standard blanket of therapy for any patient coming to the CCU. Now, coming to the pathophysiology, how actually cardiogenic shock happens. Let's go through this approach. Systolic, diastolic. If there is systolic dysfunction due to the myocardial dysfunction, due to the myocardial infarction, take the example. There would be decrease in the cardiac output, decrease in the stroke volume. That would resulting in hypotension. That would result in decreased coronary perfusion pressure, leading to the ischemia, myocardial ischemia. Clear? Now, simultaneously, due to the decrease in the cardiac output and decrease in the stroke volume, there would be decrease in the systemic perfusion. It's not only the heart or coronaries, rather the systemic hypoperfusion will happen. There would be a compensatory vasoconstriction in the form of fluid retention. System would be activated, we all know, and there would be leading to, it's not only the kidney would be involved, it would backfire to the lungs also. Now, coming to the diastolic dysfunction, there would be increase in the LV end diastolic pressure leading to the pulmonary congestion, and that would be leading to the hypoxemia. Here, hypoxemia is the most prevalent thing. And finally, there would be progressive myocardial dysfunction and death. So this is in nutshell the pathophysiologic mechanism. Very clearly understood. Simultaneously, it's not related to only systolic and diastolic or heart. Simultaneously, there is another component that is happening, that is systemic inflammation. And that's the reason why there would be also simultaneously surge of the inflammatory cytokines in the nitric oxide, inducible nitric oxide synthetase, and that would be leading to vasodilatation and decrease in the SBR. So if your patient is having this type of presentation along with cardiogenic shock, there is another shock. So the two friends are actually here meeting. The two friends are uniting here. That is septic shock plus cardiogenic shock. If my patient is having some or other features of inflammatory cytokine release, systemic inflammation, maybe I am trying to deal here with cardiogenic shock and septic shock, not only the cardiogenic shock. Now, this picture is the same like the previous one, but where we can intervene. If it is related to the coronaries, I can go ahead with the immediate coronary revascularization, red one. If it is related to the hypoxemia and decrease in the LVEDP, I would be starting with proper ventilation, give a bolus dose of diuretics, or maybe I would also think about RRT at this point of time, putting the patient on ventilator and supportive treatment. If it would be related to the decrease in the cardiac output, decrease in the stroke volume, maybe I have to think about vasoactive agents. And if in refractory cases, it would be going to the level of mechanical circulatory support, MCS. So these are some of the treatment targets based on the pathophysiology. So just for the sake of understanding. Now, what are the causes of cardiogenic shock? The next one. I am unfolding one by one. So causes, just remember SSS, 3S. Structure, squeeze, stoppage. Structure related to all mitral regurgitation, VSD, free wall rupture, all the complications of MI, aortic dissection, something related to that. Squeeze is related to obstruction, sepsis, myocarditis, myocardial contusion, some of the toxicity, unstable dysrhythmia, stoppage related to aortic stenosis, hypertrophic cardiomyopathy, mitral stenosis, myxoma, pericardial tamponade. So these are some of the causes of cardiogenic shock in a very much like you will be easy to remember SSS. But I would be again going into little bit detail, maybe acute insult, chronic insult. Acute insult in the form of myocardial, RV, LV. RV, acute pulmonary embolism, RV AMI, LV, we all know, I have already discussed it. Acute myocardial infarction, myocarditis, stress cardiomyopathy, peripartum cardiomyopathy, ventricular septal rupture, post cardiotomy, something related to that. Related to the decompensated chronic disease in the form of chronic decompensated heart failure, in the form of pulmonary artery hypertension, chronic thromboembolic pulmonary hypertension. In the LV, again, hypertrophic cardiomyopathy, ischemic cardiomyopathy, non-ischemic cardiomyopathy, restrictive cardiomyopathy, all forms of cardiomyopathy would be coming in the chronic form. Pericardial, acute would be cardiac tamponade, chronic would be constrictive pericarditis, long term. Valvular, we all know all types of regurgitation, endocarditis, cord rupture, mechanical valve thrombosis. Chronic, AS, mitral stenosis, MR. In terms of conduction defects, ventricular arrhythmia, unstable supraventricular arrhythmia, bradycardia, epinodal block, sinus dysfunction, and in the chronic form, tachycardia mediated cardiomyopathy. So these are the some of the common causes that is relevant in clinical practice. Now, coming to the restratification, IABP SOC 2 score. This is just for the sake of understanding, not a big thing. So this is the first score that has been validated against internal and external registry data. So that when they have done the catheterization in the cath lab, based on the 6 variables, age, previous stroke, glucose, creatinine, arterial lactate, TIMI flow less than 3 after PCI. So they have divided all the cardiogenic shock patients into low, intermediate, and high risk categories. Just you can remember 6 parameters in the catheterization laboratory, and that have been validated, and they have actually formulated a score. Maybe you can also have some score if you are keen into cardiac critical care. Now, till now, what we have read, what we have discussed, I'm just putting in a very much algorithmic fashion. Definition, I have explained. Phenotyping, I have explained. Identify the cause of cardiogenic shock, I have explained. Some of the key investigations that you would be doing at the emergency department or in your ICU at the time of admission, 12 lead ECG, X-ray, some of the laboratory tests. At this point of time, focus, without focus, nothing is in focus. So transthoracic, transesophageal echocardiography, lung and pleural ultrasound. Maybe if you are suspecting aortic dissection, pulmonary embolism, you can send the patient for CT, angio or contrast CT. Now, invasive hemodynamic monitoring, arterial catheterization, transpulmonary thrombodilution for advanced cardiac output monitoring, and pulmonary artery catheterization. Do you agree pulmonary artery catheterization holds a special place at this point of time? I know for other things right now we are not doing. I would be now disclosing that in the recent June 2024 Chest Journal, they have shown that evidences right now are coming up that is supporting again the clinical benefit of pulmonary artery catheterization derived hemodynamic data in guiding the cardiogenic shock treatment. And that is again especially important in the setting of temporary mechanical circulatory support. So I'm not going into detail, but it is not out of the market or out of the fashion. Pulmonary artery catheterization is still holding a special place in the advanced hemodynamic monitoring, cardiac output monitoring, and cardiogenic shock management. Now, I would be giving you step 7 to 8 steps that would be guiding you, helping you at the bedside, how you are managing and approaching cardiogenic shock from tomorrow. First step, urgently resuscitate. So we as critical care specialists always believe in the resuscitation part, and that holds true. So patients with prolonged cardiogenic shock, they need to be first ABC. So ventilation is also very much important, despite you are getting normal oxygenation parameter, because I don't want my patient to be having myocardial oxygen consumption very high. So maybe I need to put the patient on ventilator. How to do? What are the sedatives that I should use? We all know that should not be worsening the hypotension. So etomidate, ketamine, and fentanyl. These are some of these cardio safe like analgesics or sedatives. Now, patients who are not in clinical heart failure, fluid is not always bad. Always, it's not like I would say nothing is always right or always wrong. So, cautious fluid resuscitation with proper hemodynamic monitoring still holds true at this point of time. Now, there is a golden hour. Everything is right now having a golden hour in trauma, golden hour in septic shock management. So, like same thing is also in the cardiogenic shock management. 0 minute initial approach. Already, what you have to do, I have told. Etiology, you have to find out the etiology. You have to go for the scoring systems. Then managing with the initially vasoactive agents, some of the supports, fluid resuscitation. Inform the shock team in your hospital. Most of the cardiac ICUs or like advanced cardiac centers, they have a shock team. So they would be transferring to the CCU. They would be going for hemodynamic monitoring in form of like advanced hemodynamic assessment, and MCS would be immediately implemented or instituted. And they would be escalating the therapy based on the patient's response. So something related to the golden hour. Now, you should be targeting the sweet point in your resuscitation. What is the sweet point? I have already told 2.2, 18. So in forms of fluid, if you are less than having this, you can give fluid. If you are more than this sweet spot, dialysis, vasodilatation. If you are still not able to control or maintain it, you can go with inotropes, revascularization, or LVAD. So these are some of the mechanical circulatory support. Now, step 2 is take a focused history after the resuscitation and quick examination. It's always quick. So some of the important things, just differentiate. It's not always that any chest pain with shock would be cardiogenic shock or MI. It's not like that. So there are some of the confusing diagnoses also. You can have pneumothorax, pericardial tamponade, acute dissection, esophageal perforation, pneumonia also. Now, step 3, investigate urgently to confirm that my patient is having cardiogenic shock. A, B, C, D, E approach. Cardiac enzymes, ECG serial, chest X-ray, hemogram, ABG, 2D echo, focus. Clear? Now, what is the role of echocardiography in cardiogenic shock? Some of the like the trainees may be asked in their exams, or maybe it is like imperative to know what I'm actually trying to do with the focus for the heart. Evaluate the overall systolic performance. Delineate whether my patient is having regional wall motion abnormality, whether I am right now having mechanical complications of MI in the form of papillary muscle rupture, ventricular septal rupture, free wall rupture, or cardiac tamponade, and simultaneously also whether my patient is having right ventricular infarction. Now, fourth point would be, what is the cause of cardiogenic shock? If I am right now saying that yes, my patient is having cardiogenic shock, then the cause of cardiogenic shock. So we all know, I am not going into detail. Most common two, AMI and acute decompensated of congestive heart failure with myocarditis and many more. I have shown you the causes of cardiogenic shock. Now, step 5, start with the medical management. It's always the first things first. Aspirin, if my patient is having MI, I am thinking, yes, this is the most common cause. Beta blockers, calcium channel blockers should be avoided because my heart is not actually functioning well. So these are some of the cardiodepressant drugs. Thrombolysis, we all know if my patient is having MI, so I should be starting with thrombolysis, but here there is a change little bit. In hypotension, if my patient is having hypotension along with cardiogenic shock, thrombolytic drugs may not reach the coronary vessels. So maybe it is not very effective in established cardiogenic shock. Rather, I would say that maybe if my center is not having PCI facility, I should consider thrombolysis. Something is better than nothing. But I should be first trying to maintain the blood pressure and give the thrombolytics, preferably using the IABP at that point of time. So my blood pressure will be better, my perfusion would be better, and if I am giving at this point of time thrombolytics, that would reach the culprit vessels. Now, step 6, hemodynamic management. I am not going to detail everything you have to do. Cautious fluid bolus also. Start with the vasopressor ionodrops, but least dose of these medications because the heart is not ready. You are actually beating the horse to run. So heart is maybe not able to cope with all these pressures. Now, norepinephrine is the preferred ionopressor or vasopressor. There is no definitive evidence, but from all the literature, norepinephrine is the preferred vasopressor. Dobutamine is the inotrope of choice. Levosimendan is a calcium sensitizer inotrope which doesn't increase the myocardial oxygen consumption. Now, till now, what I am right now summarizing everything, monitoring, metrics to monitor and the pulmonary artery catheterization correlates. Thrombodilution if your center is having advanced cardiac output monitoring, CBP, then the pulmonary capillary things, E by E dash ratio on echo, rail sun examination, congestion and chest X-ray. And what are my treatment goals? My treatment goals are to optimize the organ perfusion, to maintain the renal as well as hepatic decongestion in the form of CVP less than 15, normalize the creatinine, LFT, reduce the pulmonary and peripheral edema, and serially I have to monitor the cardiac performance. Now, some of the pharmacologic treatment, again, we all know these things just in a form of picture. Revascularization, that means I am targeting TIMI-FLO3, platelet agglutination inhibitors, anticoagulants. Afterload, better afterload, norepinephrine, vasopressin would be increasing the afterload. Vasodilators, nitroglycerin would be decreasing the afterload. Preload, to improve preload, crystalloids would be increasing the preload, diuretics and dialysis would be decreasing the preload. Contractility, better with dobutamine, levosimendan, phosphodiesterase 3 inhibitors, epinephrine. If my patient is having bradycardia, so maybe I should be starting with atropine, epinephrine, and maybe cardioversion, beta blockers, and amiodarons to decrease the heart rate. Now, in a nutshell, in a screenshot, I am trying to give you all the vasoactive agents which are very important for the cardiogenic shock management: vasopressors, inopressors, inodilators, vasodilators. And we all know vasopressors are vasopressin, phenylephrine. Inopressors are norepinephrine, epinephrine, dopamine. Inodilators are dobutamine, milrinone. Vasodilators are sodium nitroprusside and nitroglycerin. Not going into detail, but these are some of the basic things for our understanding. Now, coming to the medical support, again, simultaneously, I have to also maintain the rate, the rhythm, and the three things: preload, afterload, contractility. I've already discussed about the preload, afterload, contractility, but maybe if my patient is not having proper the cardiac the rate, I can go for pacing at this point of time to maintain the heart rate to be around 80 to 100 to enhance the cardiac output, and rhythm with maintaining the sinus rhythm, whether going ahead with the DC cardioversion with broad antiarrhythmics. Step 7 is the most important advanced thing for cardiac critical care. That is the mechanical circulatory support in selected patients, because that is trying to prevent from going into D and E in refractory cardiogenic shock. So these devices provide circulatory support, increase the MAP, ventricular support, reduce the LV filling pressure and afterload, and also support coronary perfusion by increasing the coronary perfusion pressure. Now, some of the considerations I have already told you: whether my patient is having LV or RV or biventricular dysfunction, whether augmentation in the cardiac output is required, whether I need to decompress LV, RV, or both, whether I need to also simultaneously support the oxygenation, and whether my center is having all these things feasible to place and there is safety of placement, and some of the complications also I need to understand. Why I am telling? Because of these things. Continuous flow pumps, pulsatile flow. Just try to understand in this form. IBP is pulsatile, intracorporeal. Continuous flow pumps can be divided into axial flow, centrifugal flow. Maybe these are some of the things which are not using regularly. Maybe it is used in the advanced cardiac center. Just for the understanding sake, I would be taking 2 minutes of your time. Axial flow is related to the impella. Centrifugal flow in the form of tandem heart and VA ECMO. I would go ahead with little bit of why these devices are important. Because of left-sided support, IABP is very important. Impella is important. Right-sided support, impella, right-sided pressure, protect do you. Just remember these names. I'm not going to detail. Biventricular support, most important is VA ECMO. And we also put our patient on VA ECMO to support the biventricular dysfunction. Now, there is a proposed algorithm to decide which mechanical circulatory support I need to put in my patient with cardiogenic shock and low cardiac output. I'm not going to detail, but it is having a proper algorithm approach based on the cardiac index less than 2.2. If my patient is having hypoxemia and persistent VT or BF, straightforward go for VA ECMO. If my patient is having LV dominant cardiogenic shock, maybe I would go ahead with Impella. If it is RV dominant, I have to see whether my pulmonary artery pulsatility index is more than 1, and I would be starting with inotrops vasodilator diuresis. But if it is not responding, I could start with acute RV Impella. If it is biventricular, again, I would be thinking about changing over from Impella to VA ECMO. So this is something just for the understanding. But in the literature, like there is a question, can all these like mechanical circulatory supports improve the mortality? No. So you can see here, this is the the comment recently published 2024. Current evidence from all the RCTs has not provided clear mortality benefit. So reflection on current evidence hereby is justified. And some of the trials based on this mechanical circulatory support. Step 8, the last one, consider coronary revascularization. You have to treat the cause, the source. And for that, left heart catheterization, revascularization, go for the PCI, primary PCI. If my patient is not fit for PCI, maybe I have to think about going for CABG. If my patient is having triple vessel disease or left main disease, so CABG would be the preferred option. And it should be as soon as possible, because the shock study, they demonstrated 13% decrease in the mortality if the patient is in cardiogenic shock. And I am going ahead with early revascularization, whether it is primary PCI or CABG. 13% decrease in the mortality, and it should be up to 48 hours after MI or 18 hours of the onset of the shock. If you do not have anything, you can go ahead with only fibrinolytic therapy. Revascularization, there are certain two questions, whether PCI is better or CABG is better. Nothing like that. It is not the type of revascularization. Rather, you can go ahead whatever in your center or as per the feasibility or the patient's coronary anatomy. Whether I should go ahead with the culprit lesion only during the PCI or multivessel PCI. So till now, the literature doesn't support that I should go ahead with multivessel. Rather, at that point of time, better to go ahead with only the culprit lesion and stabilize the patient. Maybe at a later date, I can go ahead for the all the vessel PCI. So just to summarize, whatever I have told till now, etiologic therapy, optimizing hemodynamics. In the hemodynamics, try to improve the tissue perfusion with all the the things that I have told, getting the sweet spot. Improve the pump function with inotrops, inopressors. If still I am unable to maintain it, I should start or go ahead with the advanced hemodynamic monitoring and MCS, acute mechanical circulatory support. So again, this is the recent one, June 2024. Same thing, but as for the stage of the cardiogenic shock, A, B, C, you can go ahead with vasoactive agents directly at temporary mechanical circulatory support. So in the last thing, there are no definitive management. It can be varying from person to person. So need for personalized therapy is still there, and it is a complex decision sometimes. So essential to have a multidisciplinary SOC team. And maybe hub and spoke model is right now coming up in a bigger way, where you are getting the patient in some center, you are sending the patient to the cardiac advanced care centers where all the facilities are there. Now, in conclusion, rapid recognition with multimodal evaluation by ECG, biological, echocardiographic tests that would allow you to diagnose it at the earliest and also manage it at the earliest, and that would be deciding the survival. Recent classification allow better stratification of our mortality risk, and that would be also guiding us to like manage the patient efficiently. Definitely the cause, the etiology has to be at like in our like back of our mind. It cannot be like you are like no starting with all types of treatment but not treating the cause. Symptomatic management to restore the perfusion with noradrenaline and increase the cardiac output. Manage the other organ failure. It's not only the heart. Heart is the primary thing, but there are other organs that can be involved. And mechanical assist devices definitely have a bigger role, important role in cardiogenic shock, but till now, definitive no clear-cut evidence to like go for the mechanical circulatory devices at the very first instance, rather than maintaining with all the supportive therapy. Now, there is a question, but I before that, maybe if there are many like of the queries that have been posted, I would go ahead. Otherwise, I can go ahead with the last question just to summarize whatever we have discussed. A 42-year-old woman recently received some respiratory infection and was in your ICU with cardiogenic shock. When you did the echocardiogram, normal LV volume, global hypokinesia with ejection fraction of 15% with RV dysfunction as well. It is LV is normal, RV is having dysfunction. When you did the PA catheterization, you are getting RA pressure of 24 and PA pressure 68, 35, 46 with pulmonary capillary wedge pressure of 32 with cardiac output 2.8, cardiac index of mere 1.6. You have started with ino pressure, but still you are getting lactate to be high and persistent hypoxia. And now the patient is becoming more encephalopathy with frequent episodes of non-sustained ventricular tachycardia. What is the next best step in her management? Place an Impella 5.5 IABP, cannulate for ECMO, place an Impella CP, serum C-reactive protein to exclude the sepsis. This is the last slide.
The flash.
What would
Flashy.
What would be the answer? The last one.
Can you see, Dr.
C.
Tapush? Lot of people have answered.
Very well. Okay, yeah, that is right. That is right. I think that means my whole effort of like for last 45 to 50 minutes have like paid off. Yeah. So it is ECMO. Yeah, you are right. Because here the problem is with RV. Here is the problem with the oxygenation along with the cardiogenic shock. So I need to take care of the. Can you please mute for maybe 2-3 minutes more? Yeah. So I think I have tried to explain everything related to this very important and somehow complicated topic on cardiogenic shock. If there are any questions, I would be happy to take. Over to you, Dr. Saswati.
Thank you, Tapas, for the exhaustive and very, very updated presentation. I think there were some questions in the chat box. Rimita, would you like to handle them?
Yeah, I think, I mean,
I think Tapas has addressed most of it.
Most of it, I think. Yeah. Shashwat Didi, you please mention the questions because I disconnected for a while, so I'm not able to see all the questions perhaps.
Dr. Rimita, I can see all the questions and I will answer also. No problem.
Yeah.
So the first question was anterior wall. So somebody has because it is the anterior wall is mainly supplied by the left like the main artery. So definitely that is the most important part of the cardiac wall. So it is anterior. Many of the people have correctly like answered. Then there is the second one is 25% answer. So it is 25% means you will not get shock typically at the initial presentation. So that is something we need to find out, pick up in our clinical examination. Now the third question, which is related to triple vessel disease and single vessel disease. So single vessel disease, the presentation would be shock most of the time if the patient would be presented with shock, because triple vessel disease gets some time for the collaterals to develop. So it would not be that frequently associated with the severe shock at the time of presentation. Now there are like the questions how to treat the initial hypertension that might happen in cardiogenic shock. So we don't need to actually treat with like no very aggressive manner for the initial hypertension, because that is only the temporary period, the compensatory mechanisms. Maybe I need to find out why this is happening. So if my patient is needing the like no the other supportive therapy to control or like to prevent the spiraling of the events, so I need to go for that, so that that compensatory mechanism will not go to the C stage, A, B, C. So it would be taking some time. Before that, I need to stop that progress. For last, I think in like in maybe 2-3 hours we'll be going into the C stage. We all know pens and then all the metabolic acidosis and all those like no complications of cardiogenic shock happens. What is the role of nitroglycerin? It is a like vasodilator, mainly the venous system. So yes, but you cannot like go for the high like patients with hypotension, because it will further like reduce the blood pressure. So maybe if my patient is having SBR to be high, maybe I can try with that. But in patients with the hypotension and already vasodilated, maybe I will not prefer the patient to be with nitroglycerin. Which are the specific pulmonary vasodilators? I agree. Inhaled form, intravenous form. Inhaled forms are prostaglandins, inhaled nitric oxide. They are some of the like no specific to the pulmonary system. If the patient is already shocked, suddenly developed AF, it would be chemical or electrical. I would go for electrical, because chemical, I know what you are trying to say. If it is like no, already shocked with hypotension, I am right now bombarding with amiodarone. So it would further go for like no, for like no refractory hypotension. Uh, I think these are some of the questions. And VA ECMO, that impressed me. All of you like no understood the concept. Yeah. And non-obstructive hypertrophic cardiomyopathy, pulmonary edema. Yeah, we have to treat the etiology. Maybe surgical intervention at this point of time. Non-obstructed. Yeah. So maybe we have to find out the etiology. Why this has happened. It is not obstructive cardiomyopathy. It's HOCM, but non-obstructed. Yeah. What is the role of dobutamine? Dobutamine, yeah, it is a like no the best inotrope contractility. But before that, I need to maintain the blood pressure with inopressors. So that is again a little bit twisting thing. So don't feel that you cannot start with like no the patient with, you can always titrate dobutamine and noradrenaline both simultaneously. So noradrenaline role is something different and dobutamine role is something different. And I need both of the two things to maintain their specific uses. So dobutamine you can, but you have to first start with maybe titrated or cautious fluid and noradrenaline to maintain the blood pressure. Yeah, I think these are the questions. Yeah.
So thank you, Tapas,
Yeah.
for exhaustive presentation, patiently answering all the questions at the end of 1 hour. We are extremely grateful to you.
Thank you.
And thank you so much.
Thank you. Thank
So
you.
over to Rimita to close it.
Yeah. So I would also like to thank Dr. Tapush for a very exhaustive presentation, and lot of comments which came in for Dr. Tapush, that it was excellent. Right, in the chat box also we could see. So thanks a lot, Dr. Tapush. And to others, I would like to say that Thursday evenings with ISSCM, we will be doing it fortnightly and not weekly as before. So every 2 weeks we get to meet, because we thought that probably that's the interval that it will be feasible for everybody to join in. So looking forward to everybody's participation. And you can write in the group about the feedback about what you need. And we want this platform to be interactive, informative, and useful for mainly the students who are preparing for any exam related to critical care, more of the DRNB PGTs, right? So that is with that, I'd like to close the session. Good night, everybody.
Thank you. Thank you, ISSM Kolkata. Thank you, Dr. Sati, Dr. Rimita. And thank you all the attendees.
Thank you. Thank you and good night.
Thank you.
Right.